All right. Welcome everyone. And again, those of you who are joining online, welcome to the Commission on Public Health meeting here hosted here at the Baltimore County Department of Health. Thank you again to the team here at Baltimore County Department of Health for hosting us and really just being wonderful welcoming hosts. We're going to call the meeting to order and start with a roll call done by Sarah Cope, our support team.
All right. Stay present or here when I call your name. Neil Blakewell. Here. Heather Bagnall. Chris Brandt.
Here.
Jean Drummond. Nina Brewster.
Here.
Nilesh Kalyana-Raman. Ariana Howell. Alyssa Lord. Boris Lishman.
Here.
Hussein Olateju. Fran Phillips.
Here.
Nicole Rochester.
Here.
Maura Rothman. Michelle Spencer.
Here.
Alan Quinn.
Here.
Yeah.
Wonderful. Great. So we've established quorum. We'll start with the Google minutes review and adoption if the commission so moves. Commissioners, if you look in your packets, either here in person or online, if you're joining us virtually, there's a copy of the minutes from the April commission meeting. I'll take a motion for the suggestions for ahead.
Make a motion to adopt the minutes as drafted.
Thank you. Is there a second? Thank you. So motions to adopt the minutes and seconded. All those in favor, if those in the room could say aye.
Aye.
Or nay. And then online, we have at least two commissioners I heard that were online. Alan Twig and Nicole Rochester. We could just maybe support it. Thank you. Okay. Are there any other commissioners online that have joined? Okay, thank you. All right, next up is the agenda adoption. Sorry, I switched up the order there. But the agenda for today's meeting, that's also in your packets if you're here in the room or online, and the packets available on our website. Any motions on the agenda? Any seconds?
Second.
All those in favor of adopting the agenda as written? And then online, we have Alan Twig and Nicole Rochester. All right, thank you. Okay, we're going to start with commission updates from Shane Hatchett, who's our senior advisor and manager for the Commission on Public Health. He was introduced at the last meeting, but more formally since then, he's come on into his new role. So thank you, Shane, and welcome to the Commission on Public Health.
It's been great to get to connect with most of you and work with you alongside the different work groups and activities going on. I'd first like to start with an update on the Southern Maryland public listening session and the site visit in St. Mary's County. That occurred in April on the 16th. I think by all accounts, it was a really successful event in terms of us being able to kick off that first series and kind of work through any potential challenges. The primary focus of the site visit really was around school-based services and connections to care work in different community settings, reflecting the challenges that many rural Marylanders experience in terms of access to primary care. We also toured a behavioral health services center and got to see how that integrated in to the public health system as well as the broader health system. That site visit went really well. I really appreciated the suggestions that came from the county to the work groups in terms of ways that they could begin looking at improving how public health is delivered So we shared those suggestions with the work groups, and I think they've been pretty eagerly working through those, particularly as they're designing and creating their questions, making sure that we're studying the right things as we start this assessment piece. The listening session was not quite as successful, I think, as we hoped in terms of how many folks participated. Logistics went off without a hitch. Can't thank the county government enough for their hospitality. We were able to host it from the county government chambers. We only had 3 folks provide verbal feedback. I don't want to overstate that challenge. I mean, it was the first. People are kind of looking to see what this is and how, maybe they do or don't want to interact with it. We did also launch that same day the online comment form. So folks will have a variety of ways to provide us feedback. They just won't necessarily get kind of that presentation that we provide at the listening session to expose them to where Maryland Public Health is today, what the purpose of the commission is and what we're hoping to accomplish. So my hope is that they'll be able to maybe see one of those again and get some more context. But with that said, we're still moving full force ahead. Based on that site visit and listening session, have some really great notes to share with the other local health departments as we get prepared for those coming up, and I'll provide some more information on the next ones. But really looking primarily at how do we emphasize the way for folks to participate, including potentially on audio, having folks be able to call in and provide verbal feedback asynchronously so they don't have to be present. And then also looking at pushing out the dates for the site visits to community-based organizations. So creating some flyers and tables, as well as social media content that folks can continue to push out and get the word out. So I suspect that by the time we get to August, these are going to be well packed. But these first couple, we're going to have challenges based on geography, time of day, and so forth. So we'll just have to keep monitoring that just accordingly. I did want to highlight this QR code. Again, thank you to St. Mary's County communications team for putting this together. That will take folks right to the public comment form where they can provide their feedback. And we are putting that on all the flyers that go out as well. So even if they're not able to attend, they just use their phone and get to that pretty quickly. So our next site visit is in Washington County. I've been working with Earl Stoner and Danielle, his PIO there. Really excited to get together on May 23rd. The site visit will be before the listening session, but that is by invitation only. I'll be sending out a couple RSVPs to commission members and some work group coordinators to get a sense of who is interested in attending those. And then once we have that list, I'll send you the information on what the times and locations are. The listening session will be at their Division of Behavioral Health Services in Hagerstown, and that'll be at 5 p.m. to 6 p.m. Again, same setup in terms of streaming available, as well as recording and being able to kind of document that, which of course all of these comments will ultimately feed into our qualitative analysis for the broader assessment and understanding of our foundational capabilities. For their site visit portion, as we talk through their tentative agenda, they're really interested in focusing on, from their perspective, how behavioral health delivery integrates with the work that they do, particularly along the lines of substance use disorder, harm reduction programming. They also talked a little about the potential of their law enforcement engagement, particularly in terms of a diversion program that they have. So it sounds like it'll be a really good opportunity for us to get a different perspective from Western Maryland. So excited to learn more about that. Please keep an eye out for RSVPs and updates following that. And then more broadly, just to update you on the remaining sessions, as well as the potential action items here. So with the benefit of our extended timeline, we are able to kind of decongest June and July and not have to do so many of these at the same time. So as an executive group, we worked with the local health officers who had already been scheduled to offer them the opportunity to push this out a little bit. Montgomery County took us up on that, and Eastern or Talbot County as well. So their new dates are reflected here. We have Montgomery County going on July 30th for their site visit and listening session, and then Talbot County representing Eastern Shores on August 7th. I'll be working with Howard County here shortly on finalizing details for their June 3rd session. That remains unchanged from the previous iteration of this that we shared with you. With that extended timeline, again, wanted to bring before you the opportunity to talk about an extra session. Notably absent among this list is Baltimore City. And so we did reach out to the City Health Commissioner and ask if they were interested in hosting a site visit and a listening session, potentially in later August or September. They were open to that. So if the commission is interested in taking that up as a motion, we can move forward on making that.
And just for some context to that, if you recall, when we were determining the fifth location, Baltimore City and Montgomery County, there was some decision making that we needed to do, select the two options. We went primarily with Montgomery County, partly because the City Health Commissioner had just started. But now with the extended timeline, we're now moving the listening sessions into early fall. Potentially, it gives a little bit more of an opportunity to reconsider Baltimore City as well as the Montgomery County option if the commission so chooses.
Obviously, with the unique structure of the health departments and the densely populated urban area represents a different segment in some cases than we've been able to capture in other listening sessions. So from that perspective, I think it could add richness to the conversation, but open to.
No, I think from my perspective, having that additional, it fits into the timeline, and it is that sense of gathering the data. When we look at sort of the data needs of this commission, obviously it's important for us to have that outreach, right? What we're going to have to do is try to figure out, the right approach to get that community there. And while I do have the microphone, I have sort of two messages. One of which was the site visit to St. Mary's County was an extremely eye-opening event for me. And the hospitality, despite the fact that the person who hosted sits to my left, not only Nina, but her whole staff really just showed us both the beauty of local public health, but also the challenges, right? This was not just an open house, look at how great things are going. This really was a deeper dive, and I would encourage commissioners and work group leaders as sort of these opportunities come up to take that dive in at least one, if not more, of the site visits. For me, it was really, it was great seeing public health in action. Point number two is being the presiding official at the public forum. Number one, the setting couldn't have been any better. I mean, it was very official. It was, a sense of a county conference room. We had the microphones where this was being videotaped for broadcast, throughout the county. And yet what was obviously a question is, what was it that people didn't find intriguing to speak their minds on? Is it the burnout with public health? There's so many reasons we can come up with. But I think one of the things we need to analyze is to really dig deeply is, where are we going to get that feedback? It was great that we had the three people speak out, and they spoke out on passionate issues to them, right? So no one was there sort of, coming in from a strange angle, and no one came there angry. That was the other thing. Maybe that's a good thing, maybe that's a bad thing, but nobody came in angry, but in essence says, here's my concerns about what's going on in public health. We want to obviously figure out a pathway, I think, for the good of the commission and for good of that database, which is what's the community say, to be able to sort of figure out what is going to be the right formula. And the right formula may be very different in the different regions, right? So that's my 2 cents and observations.
I appreciate that. feedback for us, and that was one of the things that I shared with Washington County as the hearing, of which community-based organizations should be acting with, and how do we look at making sure that we are getting that messaging out. We also took the opportunity to restructure the press release a little bit, as well as some of the preliminary outreach information based on Cynthia Bauer's feedback on making the language more accessible and approachable. And I think that may be an opportunity for us to refining as we have more time.
And to that point, Shane, again, just really want to thank University of Maryland Health Literacy Center and Cynthia Bauer and her team there, because they did contribute quite a bit to how we give health information to the public. So, Nicole, we see a comment from you.
Yes, thank you. I just wanted to, we've been having a lot of conversations in the Communications and Public Engagement Work Group on this very topic. So I know we don't have time to belabor the point today, but I would encourage you all to maybe talk with the co-chairs of that work group. And I think my bigger comment is just to really consider engaging the leaders in the community-based organizations, and the people who are already in touch with these communities, and have them do a lot of the work of spreading the word. I think it's going to take more than what we've done. And I appreciate the efforts so far, and I'm sure we're only going to get better as we learn from as we learn from the experience a few weeks ago.
Thank you. Yeah, great point. Great point.
Summer is a time when people are not focused. A lot of these are especially not as focused to go to a county chambers and you can have to stay at work or left. So, I just texted, when are these counties having their county fairs? And that was hugely popular, lots of demographics, and these are events that are go on for days and days, and health officers can get connections to the county fair and put up a booth and have write up what he's, it would be a way of
That's a
getting
great idea.
information, because this is not a time when people are going to go to government buildings at night and give some feedback on some government stuff. I mean, it's just,
Not a deal.
does it,
Yeah,
so
that's
I'm not saying the county fair is the answer, but I just think.
That's a great idea.
There,
We can
that's
certainly
all.
communicate that to the host, the health departments in the region, because you're right, many of them do staff county fairs. They already have tables planned, and even a little flyer with give some feedback and a QR code for where people can give online comments. There's a good mechanism to get some feedback. Great thought. Any further, thoughts or on the concept of adding in a 6th site visit public listening session for Baltimore City?
I think it's a great idea, given the demographic.
Would anybody like to make a motion on that?
I move that we add Baltimore City to our list of site visits. Nicole Rochester.
Thank you. And just to clarify, do you mean site visit and public listening?
Oh, I'm sorry. I move that we host a site visit and listening session in Baltimore City.
Great. Thank you. Any second on that motion?
Second.
Thank you. Thank you. And then, all those in the room, if you're in favor, please say aye.
Aye.
Aye. Okay. Any nays in the room? Any abstentions in the room? Okay. Online, I know we have Nicole Rochester who made the motion. Alan Twig, go say aye. Did Heather Bagnall join us recently as well? I thought I saw her.
Yes, and I said aye. I realized I was on mute.
Okay, oh, no problem. Thank you. Welcome everybody. All right, so let's move then to, sorry, and are there any other commissioners who have joined online? Okay, great, thank you. So motion carries. We will confirm with the Baltimore City Health Commissioner that we would like to proceed forward with scheduling a local health department site visit as well as a regional public listening session in the Baltimore City. Thank you.
Thanks. Okay, moving forward, Obviously, at the last commission meeting, we had some fantastic updates from Boris on the impact of the legislation that extends our timeline and gives us a little more flexibility in terms of primarily the assessment portion, right? Which is really why we were looking to have these additional 3 months or so. We wanted to, as an executive group, kind of go back and build this out a little bit more, be thoughtful about it, make sure that we weren't just changing all the dates by 3 months. And so what I'd like to present to you is a concept that I think achieves that and keeps us at the right level in terms of focusing on overall strategy and alignment to vision, while taking into account the different pieces of the legislation and certain milestones that we need to make sure we're hitting. So before I show you the timeline, a couple things that I want to just kind of level set on. What I'd like this to be is more of a living document that at each meeting we bring up during this commission updated piece, reflect on where we are, what we've achieved, and where we're going, so that we're all kind of on the same page, particularly as we are calibrating with our different work groups and making sure that the coordinators and everyone else is all pulling in the same direction here. But the other piece of this is just because we have additional time does not mean that we're letting up on the gas. So folks who have reached out to me asking if they can take their work group meetings to, every other month, or if they're bi-weekly now and they're looking at maybe once a month, I've really challenged them to think through, is that the right choice? And what are the things that you could be doing to maybe bring in some experts and national resources to keep informing the work that you're doing. So not prescribing for the work groups what the right cadence is, but really trying to challenge them to make sure that they understand this is not just kind of a free pass for 3 months and that we'll pick it all up at the end. So cadence and activity is staying the same. Where we're really adding this is in the assessment phase, so that we can be really thoughtful about how we build out that scope of work. And I'll talk more about the assessment here in a bit. I have some slides specific to that, but I wanted to kind of provide this overall point first. The other thing is, few folks expressed concern about seeing June 2026 in the legislation and wondering they're kind of beholden to this work until then. The good news is you're not. The commission's work really concludes October 1st, 2025, when we submit the final reports as required by the statute. There will be opportunities to do work after that in terms of implementation and staying engaged, but the legislative piece. But it is not required that this group continue meeting or that the work groups continue moving forward as they are. So I wanted to allay any fears that there were regarding that. And not realize this is going to be quite an eye chart. So I will walk us through this verbally. And of course the slide will come out with this as well in email. But essentially what we've done is taken this and by month broken it down a little bit more in terms of what we're focusing on. So primary activity. So for example, at this meeting, we're really looking at future state visioning and how we want the public health system in Maryland to look going forward, really living into that whole aspect of the statute that says, where are we and where do we go to make Maryland better. Below that focus piece, what we've done is created 3 kind of work streams that really speak back to aspects of the legislation. So if you look at the core of the legislation, the foundational assessments or capabilities assessment is one of the primary pieces that are required of us to study as a group. So you'll see an assessment line item go through all the way until 2025 October. The other piece is what I'm calling system engagement, and that's really where we've been bringing in different speakers and helping inform the conversation and understand more about not just what's happening in Maryland, but even nationally, how we have opportunities to build upon that, bring that into the Maryland context in terms of what works here. So, for example, we've got Neil Blake Falls today from the Minority Health and Health Disparities Office, as well as Chelsea Cipriano from Health Coalition. We tentatively have Dr. George Benjamin coming in August to help round out that conversation. So really, that's the system engagement piece that we're looking at here. Things like engaging with the MDH secretary or the MDD secretary, those entities that we're required to look at based on the statute, or required to engage with and bring into this conversation for the statute. That's the system engagement. The site visits are system engagement. It's us learning more about the complexity and breadth of the health system. The third lane that I kind of see consistently in legislation here is public engagement. How are we not only sharing what we're doing, but also getting that right? I think our discussion that we just had is a great example of that every piece of our meetings needs to have some focus on public engagement, making sure that it's not just us pushing out or people pushing in, but there's a bi-directional nature there. So our listening sessions are certainly one example of that, and we'll flesh that out a little bit more. But for system engagement and public engagement, you'll see starting around September, we start to have a lot of TEDs roads, and that really represents an opportunity for us to talk today during our visioning portion with the questions is, who do we want to bring in? What are the gaps that we're seeing or feeling that we think we need to have other folks engaged in this process to help this group of individuals feel more prepared to answer some of these questions and the intent of the statute. And the same is true for public engagement in terms of how can we create some communications messaging that goes beyond just surveys and comment opportunities to pushing out messaging about public health and making sure that folks understand who we are, what we're doing, such that when this thing comes up for legislative review in 2026, people feel engaged and understand and want to be a part of that. So lots to kind of flesh out and build out more there, which is why I say this is a bit of a living document. But wanted to at least put this in front of you, acclimate you to kind of the concept and get a conversation rolling. So this is 2024 through the end of the calendar year. The major milestones here being our listening sessions and site visits. It does propose that our assessment really kind of kicks off in that July-August timeframe, just based on where we are in terms of collection of questions, finalizing some scope of work, definitions, and getting folks on board to understand who's going to be doing which pieces of that, and making sure that we've got all the necessary costs to do that. The other major piece is that beginning in September, we start to do some deeper dives into the work groups. And so in the past, we've had work groups come and provide kind of 20-minute presentations on where they are and what they've discovered. What we'd like to do is give them an opportunity to really show us what they've learned and give us kind of that sense of where things are headed. It'll be a great way for us to provide feedback to them as a commission and say, if we think, this is resonating, keep on, or that's not the full picture. I really would like to see more in this particular area, so that when we get to, on the next slide, 2025, and start looking at recommendations, there's not a huge chasm between what the commission was expecting to see and what the work group has produced. So it's kind of a check-in point in a way, as much as an educational opportunity for the work groups to share what they've been on it so far. The last thing that I want to hit on with this slide is just noting we do have an interim report due in December. So in November, we'll have to make sure that we've got everything buttoned up for that and get the reports submitted in December. So flagging that for awareness. The first half of January, first half of 2025, we will continue those deep dives into the remaining work streams and begin to kind of wrap up that assessment analysis. By this point, we really should have enough responses from our various assessment activities to be able to start making some concrete recommendations and findings. The one note that I'll make related to that is our current understanding is the PH wins data will be available in March, so that's kind of a floating nuance there to be aware of. But that certainly will be an important piece of this. The March timeframe also really represents kind of a pivot point for us, where we shift from the kind of discernment phase, the taking in of information, to, okay, what does the future look like here? And so starting in April, we'll have the work groups come in and provide actual recommendations on what they've found, and based on kind of that check-in feedback from both the assessment piece as well as the feedback from the commission that they would have had earlier on, 3 to 4 months prior. And so that's where we'll then be able to take all of this and translate it into the final report that gets submitted later on here. So in terms of level of activity and importance of engagement, I know that legislative session is always challenging to navigate, but I would say with traditional Hoosier State, this is the meat and potatoes of what we're really trying to do here. That last half of 2025, want to flag a couple of things. The first is the dates are not set normally for the traditional commission first Thursday. Part of that is trying to work backwards from that October 1st deadline and understanding that's when the report has to be submitted. That is making sure that we've got enough time to be able to do quality iterations and copy editing and changes to the drafts of the report that occur, which we have 3 drafts envisioned here. I'll walk through that a little bit more. But the other main piece that's kind of difficult to navigate around is the 30-day public comment portion on the first draft of the report. So taking all those things together, a one possible configuration, and certainly not a final one necessarily, is meeting it July 10th, knowing that that first Thursday falls on the week of July 4th, which is certainly no one's going to show up for that. Even this year, we have it a week later than normally would. If then we look at the following Thursday and providing a full 30-day period, the next Thursday would be the 21st of August, and then approximately a month later is the 18th of September. We could bump that up by a week. It is September 11th, but it doesn't mean putting that day. So all of this is really just meant at this stage for conversations, get things started. It's not set in stone. I don't expect you to bless this necessarily as much as really would appreciate your thoughts and feedback once we get this sent out to you for additional review, understanding that we'll continue to iterate on this as we go and make sure that we're building out each of these different lanes of activity in terms of assessment, system engagement, public engagement, as well as understanding overall where we are in each particular phase and kind of building our commission agendas around that and activities that we're doing. The final thing we'll say here is, again, that 2026 portion of the legislation does not require us to stop necessarily supporting work. It just means that there are no official activities after October 2025 for this group. So there will be an opportunity to continue thinking through that implementation strategy as well as social media messaging and to be the work going at least over level that whatever legislative administrative. So our draft report would be July 10th, building off of all the different recommendations and background research from our work groups first half of the year. Our second draft with the public comment portion and responses to each of those substantive public comments would be on the 21st of August potentially. And then the final meeting of this group would occur to September, which allows staff to make changes and get that submitted to the required entities, as well as making sure that we've gone back to our key formats and mandatory stakeholders share the final copies. So I feel like that's a lot, but happy to answer the question about that piece. Still have a portion on assessment that follows.
I'll have you slide on that.
Yeah.
I don't want to take up a lot of time because we have some really good speakers, so I just want to, can you go back, like, when is the focus group and interview start? When is this stuff start?
Yeah, so we are really working through those actual logistics, and the short answer is I don't have to for you. But if you'll hold just a second, I can talk more about assessment now.
I really want to compress a lot of this work so we can get these things. But I have a second, more timely question back in right now. And I guess maybe it's teed off the county fair discussion. I get the three lines that are going to go through all the meetings, which is assessment, system engagement, and public engagement. I'm really addressing the health officers in the room and online, because I want to tell you guys that you are in a place now that you need, and I know you are, helping this commission to do the system engagement and most importantly, the culture. And so between now and the end of this slide, there's going to be summer Mako. There's going to be camp fair. There's going to be local boards of health meetings if your counties are all compliant with Omar that says you got to do it sometime in the fall. So this is a shout out to the health officers and specifically to NACHO. You know, this commission is a very expert group of volunteers who are coming in from all walks of life. And what we're focusing on is really your business. Yes, MPH, but it's really your business. And so I just want to say to the health officers, give us a hand on this, okay? If you want it to be successful, if you want community engagement, it's got to be done through the health office. It can't be done in this room, and it can't be done remotely, okay? So there are opportunities that we can't even dream of that the health officers know about in your counties to talk about, hey, there's this statewide commission, and it's looking in public health. And here's the website, and here's the QR. You got to help us on this. Otherwise, it's going to be it's going to be another 3 people at a forum. So I feel real strongly about this because that's the health officer's job. And you've got an association. You've got a staff person, okay? So it's not just on you as individuals. So I just want to make that point. The opportunity, because I'm speaking from governance now, the opportunities to start the buzz with your county commissioners, your county council, and your state delegates is now. Okay, that's what Summer Mako is all about, and that's what your board of health meeting is all about. So if we're going to do this timeline, that there's actually going to be some changes, perhaps in legislation, but for sure in practice. We can't just continue to meet in this room and talk about timelines and assessments without some boots on the ground every day between monthly meetings. It just won't be true. So this is, again, it's easy for me to say as a retired health officer, okay? It's super easy, right, Barbara? Okay, you guys have nothing else to do, right? But I'm just saying, this is the time to step up and give us a hand.
Can I echo what Fran said? Also in terms of their thinking about this that particular, and I'm thinking of the MOTA grantee. Like there's so much connections and that happens across the county government. And so as you were talking, Sean, I kept thinking this is a lot that is on your plate to try and coordinate, and yet there's so many different opportunities within local government to be able to be supportive. And how could we help you? I mean, no connections are there, but if there are opportunities for us to help you in those efforts, I mean, there's a million and one ways I'm thinking from cancer programs. Like there's so much that, right? Like maternal child health here. Again, your motor grant schemes at the local level. There's so many opportunities for me.
And the willingness. So we've got
Thank you. Thank you. We'll talk some more about that because I think that. All right. Thank you.
we're a little tight on time, so she's gonna give us a high level. I know we've talked about assessment quite a bit with prior meetings, for different activities, but she's gonna give us kind of where we are with, some key aspects of that.
Yep, so the main takeaway from this slide is just a reminder to everyone on the work groups that the legislation also requires us to take a look at how behavioral health integrates or does not integrate into the current system and what the recommendations to that, as well as response capabilities to COVID-19, overdoses, maternal and infant mortality, and other major public health challenges. The final screen that really does not neatly fit within one work group, but makes sense for everyone to kind of be thinking through is procurement and contractor oversight. So those were separate items in the legislation that I wanted to make sure folks were aware of. So I won't belabor this piece necessarily because Nina's hit on it quite a few times. But when we talk about our assessment framework, we're really looking at 4 different ways of collecting information. So we've got our surveys, key informed interviews, focus groups, and the site visits, as well as our listening sessions and so forth. So really a breadth of different sources, both primary and secondary, in terms of collecting this data. With respect to the actual assessment piece and what we are trying to Brand's point, the work getting done between these meetings. Really excited to announce that we've had a conversation with the University of Maryland, CDC Foundation, and Oregon State University about bringing together different resources to deliver on the assessment scope of work. We're still working through what those actual contours are of who's doing which pieces of it. University of Maryland has agreed to take on a pretty significant portion, but of course we've got to work through which pieces of that actually will be occurring in which space, and where do we need to bring on potentially a vendor to assist and provide technical assistance. But as we look at things like getting the survey questions calibrated and reviewing the overall methods and protocols, who will be doing focus groups and training the people who are doing focus groups, analysis of our various sources of secondary data, like WINS and NICSHO, courses of change or development profiles, of course, thematic review of our listening session, comments that we've received, all those different things. Those are the things that we need to hash out, which I share not to make your eyes glaze over as much to say, we're going to bring this together through a different steering group to report back to this group. And so we need to have a dedicated group of individuals focusing on getting the details refined, working with UMD as well as United States Foundation. We'll bring back to this group. So it's not going to be a work group per se, but we'll have meetings starting as early as next week to really get this going on double time and make sure that we're able to compress that assessment schedule as much as feasible, but also be true to the process which we're collecting information.
Yes, thank you so much for that overview. As both the co-chair and the UMB rep on this, I'd just like to say that UMB is very excited about both this opportunity of assisting the commission, but also that we have the requisite expertise to look at both a path forward on focus groups and key informant interviews, as well as service techniques. Also, we've incorporated at least Morgan State and still determining their interest in terms of which part of this. So I'll agree in terms of saying we're not ready for prime time at this meeting. My hope is at the next meeting we should be able to have much more information. But I think we've made some incredible advances in terms of putting together a good package. At the same time, I'm not sure if I've done this officially in front of the commission, but we brought back a person who is a professor emeritus at the University of Maryland as a technical advisor to me on this commission, and specifically who has joined us on as a technical advisor, and that's Dr. Dejana Kleinman, who has spent many different phases in her life, which included years spent as a fellow officer of the United States Public Health Service Commission Corps. More recently, Dejana had been my principal deputy our principal associate dean at the University of Maryland, certainly comes with a lot of knowledge of what's going on at the state level, but also public health in general. So with that sort of sense of build-up of expertise, and that's, you know, introducing Dushanka from the University of Maryland, but also the team that we will bring to the table. And these are really exciting times in terms of advancing on, you know, what's going to be, I think, a very interesting and a robust assessment phase.
So the last update I have is just to mention that Senator Kelly has part of the Maryland Senate, and we're waiting on the Senate President's Office to elect replacements.
I got those hours to decide who to replace the local health officer. Thank you. Wonderful. Thank you very much, Shane. That was excellent information. And I know it was a lot to go through, but there's been a lot happening, particularly the adjustments to the extended timeline of the commission. I'd like to ask Commissioner Oletiosu to introduce our speaker. And I know she knows our introductions because she's known to us, but I think it's so nice to you. And Camille, if you wouldn't mind coming to sit here. Thank you.
I was so excited to have you here. Camille. Camille is not a listener, but she's heard. She's one of our commissioners. She currently serves as the director of the Department of Health, Minority Health and Health Disparities. She comes with more than 20 years of government service experience in policies, programs, and a lot of legislative efforts around healthcare. Camille has a unwavering commitment to improving communities, advancing health equity, and also driving transformational change. In a prior role, Camille spent 17 years as an attorney at the U.S. Department of Health and Human Services. She also worked at the Office of the General Counsel, Centers for Medicare and Medicaid. I can go on and on, but we are just really excited to have Camille here. We want to learn from her. We want to absorb everything she has to say and see how that helps us move forward. As you've heard, you know, they have a lot of work ahead, but see how the work that her office is doing is going to help inform some of the work.
No pressure, people.
Well,
First, thank you for the lovely introduction, and thank you for the invitation to present. I started my healthcare career working at the U.S. Department of Health and Human Services, the General Counsel's office, and at the time I worked. When I came in, when I started in that role, Donna Shalala was the secretary of HHS, Nancy Minza-Carl was the administrator of CMS, and Harriet Rabb was lesser known, she was the general counsel. So I came in with three powerhouse women doing work around these issues. And not long after Nancy Ann departed, we were fortunate at well, I was at CMS, but CMS was my client agency. Donald Berwick joined us soon after, and it was during Donald Berwick's tenure that I first learned. He was talking a lot about the triple aim. I had never heard of this concept of the triple aim before Dr. Berwick, and I was mesmerized because I was like, yes, you know, it's sort of like, for those who don't know, I mean, now I think there's like a quadruple or quintuple aim, but at the time it was really simple. It was like, how do we improve outcomes? How do we improve quality? How do we reduce costs? Right? I was like, damn, that is it. And something about it just sort of turned it around for me, and I've been really excited to continue that work. During my time at HHS, was really the lead attorney on tribal issues, so tribal healthcare specifically in the lower 48 and Alaska, and the Alaskan villages, and ensuring that the Indian Health Service administers tribal care, but CMS administers Medicare and Medicaid for Indians, both urban Indians and Indians who live on the reservation. And so really working to ensure equity in those spaces. And I also worked on emergency medicine issues because back in the early 2000s, we didn't have the ACA yet. And as we all know, as we all know, emergency rooms really serve as safety nets for our communities who don't have care, right? For our individuals who are uninsured. So it was also an equity issue. Nobody called it equity then, but that's what we were doing, right? For all of you who do networking. So then I spent 6 years doing work at the state's attorney's office, where we were thinking about public safety as a public health concern. It was really exciting work. And then I am here now. But before I go into the slides, which were attached, so you probably viewed them all, I want to ask a provocative question that came to me during Michelle and Fran's comments, which is, and really during Shane's presentation, sort of a provocative idea. What if we have already collected and assessed everything we need? What if we already have the data around disparities and around access, right? What if we already know what needs to be done? What do we do then? What is next? And I think in my role, I am thinking about that all the time, because I know that there are populations that we've not, that we don't have data sets for, like our new SOGI data, so sexual orientation and gender identity. There are populations, our disability community, there are populations we've not assessed significantly enough to really determine like what the needs are. But there are large swaths of populations that we have assessed and we have the data. So then what do we do with it? And I sort of challenge us all to be thinking about that over the next year and a half. Like, I think we have a lot of it. And I haven't seen us move the needle significantly enough. There have been definitely some incremental advancements, certainly the Affordable Care Act, when I was at HHS was one of them, but I just wanted to put that out there because I was thinking about that as we were going through our timeline. Not to say that assessment isn't important, I just think that sometimes we get stuck there and we don't move the needle.
I just want to point, thank you. I think as coaches, we just talked a lot about that. It's leveraging our existing data and building on that. So I think we can definitely delve into that space.
That's exciting. Yeah, I'm looking forward to that. So to bring it back around to the work I do presently for Secretary Gloria Scott at the Maryland Department of Health, I am the director of the Office of Minority Health and Health Disparities. The office was created in 2004 by legislation introduced by then Senator Shirley Nathan Pulliam. It has 22 areas of focus. I would say that some of these areas are areas that we are now doing in our respective spaces all of the time. But back again in the early 2000s, folks were not necessarily intentionally working on these issues or working on them with direction. And so there was this need to really aggregate our resources and our attention to focus on many of these points. But I will provide an overview. Some of the key activities of our office include data collection and publication. Really what that means today, because the secretary has a great handle with her chief data officer in collecting data, and we're currently engaged department in developing our state health improvement plan and our state health assessment. Lots of data collection happening across the department, but I think what our office continues to do is make meaning of that data. What does it mean, right? What does it mean when we know that Black and brown communities are deal with a greater prevalence of chronic disease, they have shorter lifespans, those sorts of things. We also advocate through educational forums and health awareness campaigns to make sure that people understand that these issues continue to exist. We have to resolve that we're not post-racial, we've not sort of addressed a lot of the dynamics that have kept certain communities underserved, unserved, marginalized. We work with our colleagues in FIPA and Public Health Service on identifying and reviewing health promotion and disease prevention strategies, and I'll talk a bit more about that in the slide. We're looking to focus on fostering public-private partnerships. I've been in conversation with some foundations in the state to see if they wouldn't sort of help provide matching dollars or fund certain programs, seed programs that legislatively we don't have enough money to fund, but that are really important. And of course, finally, assisting the health secretary in setting health equity priorities and advising on policies that relate to the equitable provision of care. So the mission of the office: to advance and address social determinants of health, reduce health disparities, and advance health equity by leveraging the resources of the department, by analyzing and making meaning of data, public-private partnerships, education, policy development, and strategic direction setting. And the vision, which is a work in progress, is to achieve health equity where all individuals and communities are in Maryland have a fair and just opportunity to obtain optimal health. And I'm going to stop there and ask folks, because one of the things about this definition or this vision is that every major organization working on health equity has their own definition of what health equity is supposed to mean, what it means, how you define it, how you know you've achieved it. I don't know if there are any other folks around the room who have a working definition of health equity that they'd be willing to offer. We have your organizations even develop one, right? And if so, what is it?
Not necessarily,
Yes.
I wouldn't necessarily, have it.
Healthy People 2030.
Really, that's one liner, and that's a description of all the pieces that are. That was one liner.
Great. Yeah, Healthy People 2030 does. There's a list for a lot of folks. Are there any other working health equity definitions that folks want to share?
It's not that big one thing to really include, additional definitions. That's really important.
I'm repeating for the people in the back of the room. Cultural responsibility,
Cultural sensitivity.
cultural sensitivity as a component of the definition.
Of that aspect.
Yeah. I agree. Anyone else? Yeah.
Yeah, you mentioned Don Berwick. So his Kid Armante is a good friend. He runs the IHI and he framed health equity in a way that I thought was really compelling as a sort of a quality imperative project.
Quality imperative.
Yeah, so if you think about the healthcare system, this was in the context of the delivery system, right? Not necessarily public health, but you know, it's a lot easier to move the bottom to the middle than it is to move the top. Like the most like we have to develop new normal, new mechanisms for you know, curing new diseases, as opposed to just, hey, look, if we execute on things that we know already, we will make a more equitable set of outcomes. And so I just thought that was a compelling way to frame health equity that no one can really, like, there is not a counter argument. I thought that was
Bringing the bottom to middle, and top, I guess we'll stay over there.
well, not necessarily, but it's that there's extra focus on that sort of, like, we're going to raise the average by sort of faster and more cost effectively by focusing on execution than necessarily by trying to allocate resources to the already short.
Yeah, that makes sense. For folks who work with organizations that haven't developed an equity statement or a health equity statement, I would offer that your organization can think about it as a first step. It's a very baseline first step to moving the needle. Like, have you even thought about it? Has it been socialized throughout your organization? And what do you define that to be in your little wheelhouse, in your sort of neck of the woods, in your corner? Can you move the needle? Because it's sort of to your point, it's sort of a grassroots, bottom up perspective. The other thing I would offer is that, you know, there's this I don't know if it's controversial, it's the idea that we have to sort of ensure that our marginalized populations, focus on our marginalized populations, disproportionate to the focus of the overall group. So we raise to your point, we raise the health outcomes of Black and Brown and marginalized communities at a quicker pace than everybody else, while not ignoring everybody else, right? That could be considered controversial, but I think that if you don't, you're going to always continue to have this balance.
If your focus is population health, the dollars are best spent doing stuff we know how to do for a large number.
Yeah. So what are we doing today in the office? We've got some, these are examples of data initiatives that we have undertaken as an office over the last couple of years. We've recently concluded a NASHP learning lab with 7 other states where we were looking at addressing health disparities from a data perspective. We're obviously supporting the work of Dr. Kalyana Raman on the data side of the Maryland Commission on Health Equity. That commission is actually migrated, or it's evolved into what will be the governing entity of the new head of Maryland model, assuming that we are selected as one of the CMS models. And I'll be talking a little bit more about ahead. I know Dr. Sharpstein spoke of that last month. I'll be talking more about that. We support the data initiatives under the MG commission right now, but again, the secretary really has a robust plan for data collection that she's really driving, and we support her in those efforts. We're doing some work we call it the ROCKY, Root Causes of Health Initiative Quality Assurance. It has been a 2-year collaboration between our office, MHHD, and public health around identifying equity of reach and equity of impact in public health, or in our various public health programs. Michelle was speaking just a minute ago about how we reach communities, and one of the ways to do would potentially be through CDO and grantee partnerships. We have 4 grant programs, and I'll make a plug. We've just dropped 3 of these 4 programs on the street for public applications, and that application deadline closes May 20th. Local health departments are eligible to apply. Any community-based organizations are eligible to apply. I will leave this for you to read at your leisure. It's Minority Outreach and Technical Assistance Program, which is our legacy program. Those funds existed before the office did. They were part of the Cigarette Restitution Fund, the Social Determinants of Health Program, grant program, which its name sort of describes what that focus is. And then our ELC COVID program, which relates to dealing with issues that continue for communities who have sort of been significantly impacted by COVID. We have also our newest program. We are the fiscal stewards of the Sigma Cell program, partnering with Johns Hopkins University of Maryland on that. Okay, there we go. Okay. I've spoken a lot about, in the interest of time, I've spoken a lot about our focus areas, but a couple that I'll highlight here that I hadn't discussed are strengthening community capacity by working with community health workers and community-based organizations. We are currently engaged, or we have been engaged in a department-wide equity assessment. When I arrived 9 months ago, I wasn't sure what the department was doing around equity. It had sort of sprouted up organically in various administrations and shops, but there was no sort of cohesive central steering committee of the work. And so I've been trying to get a sense about what's currently in existence so that we can build on that. That work is ongoing. Our data analysis is ongoing. But this is really key: developing and promoting internal and external practices to address structural racism and to reduce the impact of the social determinants of health on communities. I really think that, and this is the philosophy upon which I base this office, we have to deal with the upstream drivers of health. Health and wellness is different from healthcare, right? And we know that. Like, what if a community is well or a community is healthy? It's very different than if an individual in that community is well or healthy. And so I think we are moving away with the social determinants. We're moving away from social determinants of health to health-related social needs as a nomenclature. Health-related social needs really do, to me, speak to the individual. Social determinants of health really speak to the collective. Fran and I were just talking about that. But I think that there's a distinction that's worth making there, because when we, it's like American individualism, if we sort of think about getting Camille well, we don't think about getting Camille's community well. Camille will get sick again, and the rest of her community is suffering, right? So we have to think about the root causes. And health equity, I think, demands that. These are all just my personal opinion. I share them with the secretary. She knows how I feel. And to that end, part of our work at MHHD is, to sort of support the work of the secretary and of MPH more broadly. And I think I might have go back. And so we're doing that by through our grant programs, supporting our grant community partners, supporting colleagues who are doing health equity work. We're leading some cultural competency, implicit bias, language access, and technical assistance training. And we're trying to start, I met with Dr. Brookmeyer, I've met recently with the local health officer in Harford County, Baltimore City, to try to begin to have relationships and conversations with local health departments, many of which are much farther along than I think, the department is in seeing sort of what's happening and how we can support. I think I've covered everything on the areas of future focus. So I will skip that in the interest of time. The one thing I'll mention is another aspect of our work is to really try to focus on Maryland's healthcare workforce and bolstering minority representation in the behavioral health space in particular. We have underrepresented behavioral health professionals, and there's now a working group that's addressing the underrepresentation of BIPOC behavioral health professionals, and I and Stephanie Slowly, my colleague at MDH, are leading that work group to try to propose make recommendations to the legislature for 2025 to increase the roles, because we think that will sort of help with effective cultural competency and cultural awareness. And so that leads me to the future of MHHD. One of the things I'm really excited about, in addition to continuing this work with our colleagues at MDH, is creating a steering and equity steering committee within the department. There will be health equity liaisons embedded in each major administration and office, because I and my staff can't be everywhere. And their charge will be to bring forward these issues of equity in every policy, program, procedure that's being developed, and we will meet monthly to sort of talk about what's sort of percolating and make sure that we are speaking with one voice and we're pushing through these issues and weaving them in. And the one thing I'll say about this, because we were talking about the assessments and looking at procurement and contractor oversight, I would just offer that budgets are moral documents and they reflect what we care about. So when you are entering into relationships with contractors, with vendors, and you're setting your organization's budget, it's a question of equity can be embedded there as well. How are we ensuring equitable disbursement of funds and support and resources to sort of put our money where our mouth is? So I'll stop there. Actually, let me just get through these and then I'll take any questions if you have any. So that's our office. I've been in the office for 9 months. I'm just scratching the surface, lots to do, lots to address. We are in a rebuilding phase, but it's all very exciting. A part of my work as the MHHD director, secretary asked me to join Elizabeth Fromm, who is the director of the Prevention Health. What is it? I can't ever get it.
Promotion.
Thank you. Prevention and Health Administration within. So they are like our in-house LDH, local health department, right? That's sort of how they function. Elizabeth Fromm is the director of that office. She and I were fortunate enough to head up the Population Health Transformation Advisory Committee. It was one of the 3 committees that were convened to help the secretary. Can't see that here, but you printed it out. Those were our members to help the secretary and the HSCRC chair, Dr. Sharpstein, and executive director, John Crum, think about how we are going to draft our application. So I won't belabor the ahead model or what is expected there, because Josh did that last time. But we were one of the 3 committees convened to support the application development process and to hear back from colleagues in the community. Our charge of the population health TAC, which is what we called it, was to advise the state on the approaches to health equity-centered health, to equity-centered population health improvement. So we met twice, once in March, once in April, and we spoke with folks from all across the state. I think 130, there were 130 applicants to serve on the TAC, and we had about, was it 20, 25, 24? And we spent several hours together talking about how we advance equity and population health transformation. I know this is small to see, but you all have the slides. You can read it on your own time. I just wanted to share this was the vision that was developed by MPH in advancing our AHEAD model application. At the center is equity and excellence in Maryland's healthcare delivery system that improves the health of all. And you can see that continuum of care, where we're touching the community, primary care, specialty care, hospital care, post-acute care, palliative care, end of life care. So that coordination of care, continuum of care, and undergirding all of that must be equity, centering community, and population health. This is hard to see, but I'll simply say that for purposes of assessment, like we were talking about under AHEAD, CMS will expect us to set during our pre-implementation phase, which ends in December 2025. We've got to set some statewide equity targets and measures. They will give us 5: population health, prevention and wellness, chronic conditions, behavioral health, and healthcare quality. And then we have the option to elect 2 additional: maternal health and prevention. And we will report on those metrics annually, those targets annually. Each hospital will also be required to create its own health equity plan. Well, each hospital will be required to create a health equity plan along with the state. The state will create a health equity plan, and that committee that I was talking about, the Maryland Commission on Health Equity, will be the vehicle through which we will create that plan. And we will be monitoring hospitals' health equity plans. Those also have to be developed annually and targets set. This is all a requirement under the new model. Enhanced demographic collection, data collection is also a component of the AHEAD model. And a real focus on health-related social needs screening and referral. So looking at C codes, ICDs and C codes, and all the other ways that we try to think about screening for social determinants of health. The one thing I'll say about this, and I've been thinking a lot about that, and I'd love to hear feedback, not necessarily today, is sometimes when we talk about creating bi-directional referral systems or capturing data like via Z code or something, we've got communities who may be reluctant to do that. Like if I ask you about your child, might you come take my child if you give me the kind of data that makes me think that their child is unsafe, right? So how much information am I going to give you if I think there's any concern that social services is going to be seeing that to potentially take my child? So we could screen for health-related social needs and social determinants of health, but I think we have to, change moves at the speed of trust, I say. And so we're going to have to create systems where our community trusts us that when we collect this data, we're not going to do something with it that's going to harm them, right? And so I think these are the nuances that we have to think about. I think we definitely need to start collecting the data, but we have to make sure that we create frameworks that people want to share that and feel trusted in doing so. I've been thinking a lot about that. I don't know what to do with it. I just think about it. So finally, let me get to what I think is the most interesting piece of our PTAC sessions, which were the summary of comments. Again, you will find them in your deck, so I won't need to go over them. But there were some, we bucketed the topics that we touched on: the definition of health equity, what we need to do. The next slide. It's entitled Maryland's Foundation for AHEAD, but really it is, what do we need to do to make the Maryland model successful? Should we focus on just a few priorities? How do we involve the community? Do we need more granular data, or do we have enough data? Are we collaborating across all of our delivery systems? Is everybody at the table? There we go. Here's that. Let's see. My apologies on the screen. Accountability, something we didn't talk about, but when we talked about when we were talking about our expectations between now and December 2025 or whatever it is, at the end of our time together, how do we hold ourselves accountable? How can the community expect that what we do here in this body, we're going to do? right? It's one thing to have a bunch of recommendations, but if we are not accountable to if we work for them, we're not accountable and we don't set up accountability feedback or accountability opportunities, then one, you're not going to get folks to the table because it's like, I worked out and it doesn't matter. It's not bi-directional. They really don't care what I think. And they're not going to tell me how they're doing. And if they're failing, they're not going to do anything about it. We have to address that. I mean, people will only trust us when we start to hold ourselves accountable. And there was some discussion of that during our PTEC session. Upstream funding. Are we giving enough money to our community-based organizations and those really dealing with the social determinants of health? So that downstream, when we're thinking about, like Dr. Sharpstein was saying, health outcomes and health care, we reduce hospital utilization. Like, how do we do that? Well, we get people healthier and we get their communities healthier water, healthier air, food deserts, housing, transportation, childcare, all the things we know we need to get people and families healthy so they don't need to take the hospital. Yes.
I mean, the fear, I 100% agree with this, and I'm excited for you to be here, actually, because I think for sure. And like really excited about the head model and the opportunity of PTEC because it's a real funding opportunity for an actual public health. I just like one concern I have is that we try to boil the ocean. If you go after housing and air quality, it's just there's no chance because we will try to boil the ocean with the agency or sea, right? So, yeah. But if you like the opportunity to lead the nation on maternal mortality metrics that are like major public health metrics, right? Or infant mortality metrics, like lead the nation that disproportionately will benefit minority communities, right? If we just look at quality, like that no one can agree, like no one can disagree with the idea that we could improve maternal mortality or infant mortality. We should, and this is a great place to get money to do that. And it ultimately is public health and health equity, but the opposite. And so it's just like I would encourage us to focus on measurable goals that the delivery system can have a part in, but that are major public health offset. And if we can help with that, please, in terms of helping give voice to it, that's the only.
I mean, for me, that point, and I'm short on time, it's really a both and. I both entirely agree, and I think that's why there is this shift to health-related social needs, because there's this notion that we have to keep individuals healthier. Like, how can we change the metrics for Black and brown women across maternal and their babies' maternal mortality? So we can address those and reduce mortality and morbidity. We are having an impact. But if I have that child and I can't feed them and I can't house them and I can't educate them, and so I agree, it's like boiling the ocean. So my job, and the beauty of my job, I just get to talk about keep us centered around what I think are some of the issues that we can never get too far from. And I will trust all of you to be thinking about the ways that we operationalize that, create metrics for that. I think there has to be a both and, because I will tell you, in 2024, we have been trying this approach of dealing with like individual assessments and targets. And I mean, CMS is our current model has targets and incentives built in. And we've made some improvement. I don't want to disband. Maryland is like leading the state and the nation in lots of ways, but we are still so far behind. And so I would just offer us to consider, like, we can't boil the ocean, and we also can't keep doing what we've been doing, because I have not personally seen, all of the, there's an opportunity for more, and it's a both and. I don't disagree with you, because how do you even quantify? And I think Dr. Sharpstein said that, like, he's interested in health outcomes. He's like, how do I reduce utilization in a hospital? Like, that's what I care about. And I'm 1,000% with it. And I think about that single mother who doesn't have the red line to get to a job that pays enough to pay for childcare. And so what are the implications there? So I'll get off my soapbox, but it really, let me advance just to say, I wanted to, lots of comments, you could read them on your own time. But as we think about public policy visioning in this group for the rest of the afternoon and for the rest of our time together, when we think about the implications for public policy development, in order to accelerate health equity really, truly, and maximize impact, what factors matter most and in what order? Is it improved access to care coordination? Is it workforce development and training? Is that cultural competency? Is it timing? Is it time? Like, we need more time. We need to do it at a different time. Those are like political dynamics, funding, social, environmental, and political dynamics. Or do we need a shared vision across multiple sectors? And these are just some ideas. Like, what do we need? How do we scaffold this? What do we do? And what do we do first to really move the needle? It's really an open question. We're not going to solve it here, but I wanted to leave you some food for thought. And for rushing, thank you so much for your time. Happy to take questions.
Oh, very, very, like you said, just very thought-provoking questions about the content. And certainly incredibly meaningful for us as a commission. We do have that visioning time as well that we're hoping to incorporate into today's meeting. But I think some discussion might come up there as well. Does anybody have any immediate questions or comments, or should we move to our second presenter?
I have a question about the data, some of your recent initiatives.
Yeah.
I'm looking at the website now, the NASHP thing, in those, let's just find some of the data, or would it be an ask?
Well, the NASH, I don't know that NASHP sort of has anything published yet. I think we'll be one of 7 states looking at data initiatives.
Okay.
On the MHHD website, you'll find our 2023 annual report. And in the annual report, we do provide some data over chronic conditions, some of the chronic conditions that we've been tracking. We say a little bit more about the ROCKI, the public health work we've been doing to track equity of reach and equity of impact. You find some data results there. And if you go to our MHHD website and look for annual report 2023, you can find some data there. But I will just say that the secretary is, I just looked, she's rocking and rolling with creating databases that the public can utilize to pull down like opioid overuse opioid use and whatnot. So it's more to come on that. We should be able to access all of that. It's been a question that we get asked a lot. She's really leading that initiative. Thank you so much.
Sorry, one more actually. Rochester, Nicole Rochester online.
Sorry. Yeah. Yes. Hi.
Hi, thank you so much, Camille. That was phenomenal. I'm really looking forward to spending some more time going through the materials that you submitted. My question is around, do you have, well, I don't want to say do you have concerns, because I'm pretty sure you do. So like I guess my question is, what are your thoughts about the current threat to the very work that you just described with regard to the political climate? And we're talking about the need to diversify the healthcare workforce as an example, while we're seeing universities eliminate programs that have historically increased the number of minority healthcare workers. And so I guess my question is, what are your thoughts about that? And are there any strategies that are being considered to really kind of protect this work?
Yeah, really quickly. I think about it all the time. I think bottom line is it can't be a moral imperative anymore that we do the right thing and diversify our workforce and treat everyone equitably and get everyone healthy. I mean, I think we have been able to, I think in these DEI spaces or when we talk about equity, we've been approaching it from this perspective that it is the right thing to do. It is the fair and just thing to do. And it is the fair and just thing to do. That is not going to carry the day. My approach is make the business case for why healthier communities, will drive economic development, investing in education for young people will create the next generation that can create things. Healthier kids mean that parents don't miss more work. Like, you make the business case for why people should care about healthier communities, and you don't have to couch it in it's the fair and just thing to do. That is not going to win the day for lots of people. But if you make a business case out of it, you're going to be more inclined, it's been my experience, to actually win the day.
Thank you.
Yeah, okay. I'm really gone now. Okay.
I'm gonna, if everybody's all right, I'm gonna take the liberty of just moving us to a short break first before we convene with our next speaker. So we're gonna break for 5 minutes or 7 minutes or so. Let's reconvene at 3:40, and then we'll move right into the second speaker and then discussion. Thank you.
Yes, thank you. Yeah, we were.
Love it. Yeah, love it. Well, I don't.
I know. I'm sorry.
I
know that she was working on it.
Yeah.
6 weeks ago, so I think those are going out and then they'll be
All right, we're gonna go ahead up and start again, and we'll let everybody inside here in the meeting room take their seats.
Turn around the blood pressure of X number of our clients. I mean, you could.
There's also that. Yeah.
All right, welcome back, everyone. Thank you so much for being with us on that short break. I know we've got a lot of content we'd still love to cover. So please just stay tuned for if we need to adjust the meeting agenda as we're moving along. I can see that. I'm going to pass it over to Commissioner Forrest here.
Great.
Lucia Nectar to introduce our next speaker. Thank you.
Thank you so much, Nina, and we'd like to welcome on to our panel here today to discuss collaboration between public health and healthcare delivery. Our presenter will be Chelsea Cipriano, who's the managing director of the Common Health Coalition. Chelsea serves as the managing director of the Common Health Coalition. As I mentioned, prior to that, she served as executive director of government affairs and the deputy public information officer during the COVID and monkeypox responses for the New York City Department of Health and Mental Hygiene. She also served within the New York City Mayor's office, first as a senior health policy advisor, then as deputy chief of staff for the Office of Management and Budget. She's had additional multiple roles in public health at multiple levels of government, including within the CDC and U.S. Department of Health and Human Services. So we welcome Chelsea to our happy family of commissioners and visitors.
Great. And thank you. And Chelsea, I just want to, is it okay if I know she's having connectivity challenges, but Chelsea, if you're on, can you just confirm that you're on with us today?
I am on. Can you see me? And
Yeah.
hear me? Okay.
Thank you so much. Chelsea has had a very active week and incredibly busy afternoon. I'm surprised she was still able to join us. If you'd like to share, feel free, Chelsea.
Yeah, thank you so much, Mina. Hi, everyone. I'm really happy to be here. What Mina's referencing is that I've been in 2 tornadoes this week. One on Sunday night on a highway at a Love's gas station, where I had to essentially force the store owners to let people from inside outside to shelter in place off the highway. It was really crazy. And then today we had another tornado warning, and it touched down not too far from here. So I am not sure what this says about me, and like maybe I'm a magnet of some type. I'm based in Louisiana, but this is quite unusual. So anyway, I may be a little bit more animated than usual because the adrenaline is really pumping this week.
Well, I'm shocked that you're with us. I'm very, very honored that you have found a way to join us here in Maryland to talk with us. Are you comfortable sharing your slides, or would you like us to handle that for you?
If you are able to do that, I'm comfortable. I don't know how stable my connection is right now. The Southern power grid is not so great. I have learned. I'm new to Louisiana, and after the storm, I just don't want it to go out in the middle of my presentation, if that's okay.
Absolutely.
Great.
Please go ahead. We'll get those loaded up for everybody who's joining us.
Amazing. Thank you. And so the slide deck starts with a video. So we'll start with that once it's all loaded up. But just by way of quick introduction, my bio said probably all you need to know about me professionally. I started my career in federal world and went down to local world, although local and New York City, it's not like the most local, form of government. I was raised by a local public health director in rural Connecticut. So my frame of reference for when I talk about local public health is really like when the director, I'm sure many of you can relate, is also the communications person and also the epi or in charge of the sanitarians, not the New York City Health Department where I worked. And then I'm previously an EMT, so I come to the work with a clinical background myself. And I am married to an ED and critical care doctor who is not here today, but is usually in the background saying, that's not realistic for real primary care providers, as a reality check of all of the big pie in the sky things we like to promote as public health or big system thinkers. So That's where I'm coming from in the land of reality. And I'm really honored to be here with you today. I have long looked at Maryland in general as a exemplar in both public health and healthcare, from the way you deliver care and work with data and exchange data and pay for it. It's really interesting to learn about. And now it's just been great to listen in on this meeting and be among those who are actually doing the work. So thank you so much for having me. I'll do a quick introduction to the Common Health Coalition via this video. It's a minute, and I hope you enjoy it. So I think the next slide is the video if it will play. Perfect.
Healthcare and public health are two critical pieces of America's health system. During the height of the COVID-19 pandemic,
May not get the sound as easily. Let's try do this. Yes. Oh, thank you. All right, so Chelsea shared the YouTube video. If you'd like to check that.
Yeah, I put it in the chat. If you want to watch it afterwards, it's really not essential. It was just gonna be a more interesting way of presenting what we're trying to do here than me talking about it, but I'm happy to do it. I can give a quick rundown. So I think we can go to the next slide and then folks can watch it on their own. Thank you so much. So the Common Health Coalition essentially came together when Kaiser Permanente, the American Hospital Association, the American, Medical Association, AHIP, formerly the Association of Health Insurance Plans, and ACHP, the Alliance of Community Health Plans, 5 players who don't traditionally work, hand in hand across the healthcare space, came together and said, we saw the power of healthcare working hand in hand with public health during COVID. We want to see more of that built into our everyday infrastructure. I think those of us who have been in this space long enough at multiple levels of government or otherwise know that healthcare and public health too often operate in parallel. We don't share data, we don't share information sometimes. And from systems issues and relationships issues, we just aren't always working in sync. And there are great examples where that is not true and where partnerships between healthcare and public health are what are driving positive health outcomes. Both during COVID, we saw a lot of those innovations come to light because with emergency declarations, barriers to exchanging data and deploying staff and really working hand in hand through MOUs to deploy resources and humans fell away. And we saw the potential for getting resources where they need to be in an equitable way faster than we've ever seen before. So what the Common Health Coalition came together to say is that should be our norm. We shouldn't operate in parallel. We don't want, these best learned lessons from the height of the pandemic to go away and for us to just return to 2019 and say we didn't learn anything and we will never have to do it again, because I think we all know that's not true. And so we came together, these organizations came together, and then I came on board with Dave Choksi, who is the chair of the coalition, former health commissioner from New York City, to essentially develop recommendations, is what it started as, for how to advance work at the intersection of healthcare and public health, both for healthcare and for public health together. What we are not here to do is, one, very important to me, tell public health what to do from healthcare. That's never a winning approach to this, and so that's not what we're trying to do. 2, importantly, not trying to reinvent the wheel. I think those of us who have been in the space long enough know that there are many, many, many recommendations of how healthcare and public health can collaborate better and what it can look like, and woulds, shoulds, and coulds. And all of that research is really important. It was the basis for what we came out with. But we wanted to focus on action, not just recommendations, and not reinventing the wheel or saying that, these strategies that have been in place for years haven't been working. So what we came forward with were commitments. And so these commitments are driving action on behalf of these 5 founding organizations across some spaces, which I'll go into in a moment, to pursue this vision, which is really acting as a bridge between healthcare and public health to amplify, replicate innovations that have happened on the ground and are working, and that all too often the people doing the work are busy doing the work. And so they're not always out there writing the papers or going to the conferences or able to talk about their work in a way that enables others across the country to pick it up and say, I've been wanting to do that, or we started that. It didn't go so well. I'd love to talk to someone about how they did it successfully. So that's what we're aiming to do. And we want to see more organizations join us. And so that's what I'll talk a little bit about today. But that's what we're here for, not reinventing the wheel, amplifying what's out there and what's working and trying to move the needle forward on this collaboration. So I won't read what's on the screen. I know you've had the slides in advance and you'll have them afterwards, but I'll quickly go through. Next slide, our commitment or our approach. So we've taken this approach that we call CARE. These are the 4 areas of focus. 1 is coordination. What does that mean? That's really the relationships that all of you, I'm sure, have with your local healthcare institutions, state healthcare institutions, insurers, and others. But ensuring that all was a little too familiar to many of us in the middle of the height of the pandemic, as we were sitting around a table with lawyers trying to figure out MOUs on how to share this information or these staff or set up this dashboard, that we're not doing that again, that these relationships and agreements are in place should we ever need them for another health emergency or everyday crises like chronic disease, maternal health, and overdose. A is always on emergency preparedness. This is ensuring that across hospital systems and public health, through existing programs and other creative approaches that we've seen come out during COVID and beyond, that everyone is really playing from the same sheet of music. I think we all know that different health systems have different guidelines and requirements and standards for their emergency preparedness plans, as do health departments. How do we align those standards so that we're all working from the same sheet of music when an emergency happens? R is real-time disease detection. This is really speaking to electronic case reporting, electronic lab reporting, these mechanisms that we know work but aren't being implemented at a large scale across the country yet. And then E is exchange of data. This is really getting at the issues of interoperability and just ease of data sharing within systems and between systems and with public health for really ability to deploy resources and get the public's trust by being transparent about what's happening on the ground. Next slide. And so these are the commitments that we came out with. I will not read through these. There are 6 of them. There are 5 plus an overarching federal nod. You'll note that in all of these, we're not talking about huge federal action because our focus is being really concrete, action-oriented in 1 to 2 years. And I think we all know that if we want action in 1 to 2 years, that's at the state and local level more often than not. That's through voluntary work. That's through agreements between partners who have learned each other's needs and can openly communicate honestly about what they are and figure out the mechanisms to create agreements to address them. And then our last commitment is about supporting federal efforts because we would be remiss not to mention that they are happening. So these are the commitments: establish and codify coordination, collaboration, more easily get staff when and where they're needed. That's about, staff deployment and emergencies, share data in real time to advance equitable outcomes, both with each other and the public, expand electronic disease reporting, and then standardize readiness across the healthcare system. If you dive into our website, which I'll put in the chat as well, you'll also notice that within each of these commitments, we talk about actions that the 5 founding organizations have committed to taking to advance these commitments. These are really high-level things. So what do they look like in action is a whole nother, another conversation that we've spent all the time on today talking about. But it's also not going to be a one-size-fits-all for each organization, whether we're talking about healthcare organizations or public health. Everyone has different levers that they can pull and different angles and different political situations and budgetary situations. And so one health department may have a great way to go about establishing and codifying collaboration, while another may say, well, I know the guy at the hospital and I'm going to ask him to set up a bi-weekly meeting, right? A low resource, more relationship-based approach. That's great too. So the actions are really there as guideposts for how to move these commitments along over the next, again, 1 to 2 years. Next slide. And then these are just some examples. On our resources page, which I'll also link in the chat, we have what we call the Common Health Compendium. It's essentially highlighting stories from across the country of what these commitments actually look like in action. And even though I've been talking a lot about infectious disease and emergencies, it's not just that. We know that exchanging data, getting staff where they need to be, collaboration, and using all of that to drive equitable outcomes is just as important in a timely way for maternal health and maternal morbidity and mortality and overdose and mental health, as it is for hepatitis C and syphilis and H5N1 and measles and other burgeoning things that we're facing today. So these are just a couple of examples. Of course, I don't have to talk about Maryland and the HIE here. I think Maryland, I could have put 5 examples just for Maryland up here, but that's on my next slide of what I would love from you all. But these are just a couple of examples. In New York City, we had a partnership with insurers to essentially identify under-vaccinated populations and then pay providers to advance, progress in those under-vaccinated populations in a really targeted and secure exchange of information partnership way. There's no reason why that needs to be exclusive to COVID, right? That would be effective for a number of conditions. In Minnesota, they're really leading the way on electronic case reporting that happened during COVID, but they're seeing that as the infrastructure was established across the country, we're seeing this. You can do a lot with electronic case reporting that isn't just COVID related, right? In Indiana, you all may be aware of the Health First plan in Indiana. It's a legislated plan, essentially directing the public health direction for Indiana for the next several years, and there's investments tied to it. And now the Hospital Association in Indiana has signed on to pledges to essentially work with public health to advance that plan. I think it's fantastic and seemingly simple, but took years of effort on the part of the Indiana folks, and look at the result. In Dallas, through MOUs, they have been exchanging data since COVID days, but really with the county health department in ways they never had before, and were able to develop more focused and targeted approaches to addressing the inequities they were seeing in the data. So these are just a couple of examples. And if you look at our Common Health Compendium, we have examples broken out by each commitment. And really what I want is to keep building out that compendium to ensure that the stories from the ground are being told, that when someone has a great idea for an intervention, they can go to that compendium and say, is anyone else doing this? Right? Is there anything else out there? They don't have to go to a conference to get it. They don't have to go through an association or membership organization to find it because it may not be there. I want the compendium to be a growing and evolving resource for everyone to both learn from and amplify the good work that's happening in a really low lift way for you all. So my ask on this is, if you have stories to tell from your work that are already published and we can link to or summarize on our website, let me know. I would love to do that. I would love to get you that amplification from the ground. We have stories in there from small health departments to large health departments in cities, tribal health departments to big hospital systems like Kaiser and Geisinger and beyond. So academics all across the board, we're looking for stories from anyone who can really elevate these principles and show them in their work. And then finally, next slide, I'll just say, and then we'll jump into questions. I think we are looking for organizations to now join us, to grow beyond the first 5 organizations, the founding organizations, to do this work. How do we focus at the intersection of healthcare and public health? Dr. Brewster and I have discussed really honing in even on the intersection of primary care and public health, right? Like, let's get as granular as you want to get and figure out what resources organizations need to do this work better, to learn from others, and to not have to reinvent their own wheels every time there's an administration change or new leadership. We've heard from folks it'd be really helpful to have webinars, right? So webinars where kind of the lower barrier to entry than a conference, where you can come. We'll have a couple of exemplars who have done good work through MOUs or through agreements through staffing plans and ECR. Come hear from them, ask them questions, open office hours, essentially, to meet new colleagues who are doing the work that you're interested in. We've heard that it would be helpful to have templated MOUs, templated data sharing agreements, even templated emails for smaller departments who may not have a CMO contact at a local hospital or an institution nearby. You know, I think a lot about my family in Connecticut and how, you know, when people retire, your relationships can retire as well. And so building those relationships isn't always easy, particularly for smaller health departments. So those are just some of the resources we're working up. As members, you'll have access to the webinars. We are rolling out, you know, bigger initiatives to come around particular health issues. We're obviously now focused on this like building system capacity and sharing stories, but in the future, focusing on 50 states, getting on board members, and then also how do we hyper focus on a health issue and show these commitments in action. And it's free. So joining is free. Or signing up is essentially an affirmation that you support this work, that you're on board, that you will make a commitment and take an action in pursuit of it, and then access these contacts and resources and help us build truly a movement to try to ensure that the lessons learned from COVID and beyond are not lost at the intersection of healthcare and public health. I think that that's probably all I had in terms of the presentation itself, but I want to answer as many questions as I can. Like I said, I'm so excited to be here. Maryland is, there's still a lot to be done in Maryland, but from what I know and what our colleagues, you know, have shared about Maryland as a state and then localities, you're really far ahead, like I said, in terms of data sharing and payment and healthcare transformation and population health. And so I think I would be happy to elevate and amplify your work through the compendium and other settings, and would hope that you'd consider joining the coalition. So I'll open it up for questions. Thank you.
Thank you, Chelsea, very much. And we really, again, I'm astounded that you're joining us despite the circumstances, but very, very appreciative of you sharing what's going on with the coalition and the building of momentum nationally that's happening in that intersection of healthcare and public health. Any of the commissioners here in the room or online who have some immediate thoughts or questions for Chelsea? Thank you. I know when we've had a lot of discussion, and as we talked about, you and I, we've had a lot of discussion in Maryland, of course, about this idea of collaboration and deeper collaboration, not just coming to a meeting together and talking about when a plan's going to be coming out for a community, but really looking at sharing of resources, sharing of staff, perhaps.
Right.
And so forth. A lot of those issues you mentioned as important issues that we attempted to navigate during COVID as well, during the pandemic phase of COVID. So I'm curious as to what you've been seeing around the country as we emerge from that pandemic state of critical, more integrative collaboration between healthcare delivery systems, whether that's hospitals or primary care or other, and actual health departments, the governmental health department units at local or state levels.
Excuse me. Yeah, I appreciate that. I think that there were a couple of really foundational, I don't want to say truths, but like lessons, feels silly to say, but learned through COVID or amplified through COVID. I don't think they were lessons that anyone didn't already know, particularly around involving communities in decision-making and ensuring that we aren't just going out there, whether it's healthcare, telling public health what to do, or public health telling communities what to do, blindly assuming that people will follow guidance or requirements. And so I think a really interesting part of this has been to see not just the intersection of healthcare and public health, but then also the tie-in of CBOs or faith-based organizations into a more authentic infrastructure. I know the CDC Foundation is doing some work on this right now, but even in our work, where we're looking at what public health departments have done, we have seen the more natural tie-in and seemingly like an attempt to maintain that tie-in, not just use it during times of exacerbation. I think the focus on equity as not just like a thing we talk about, but a true, Camille said this, holding ourselves accountable to equity, whether it's building in equity metrics into outcomes and working with healthcare to figure out what they are seeing in the clinic setting. And sorry, I'm not sure if that's me echoing what they're seeing in the clinic setting, and public health using that data to then really be bi-directional with the data back to healthcare to drive interventions. Mina, you and I talked about this a bit, where healthcare often feels like they're giving public health data and then not seeing what's being done with it, right? And that doesn't then incentivize in a non-monetary way. It doesn't incentivize healthcare institutions or even providers to really care about giving the data outside of what they're required to do. And I think during COVID, in many places, what we saw is providers were entering data, it was going to the health department, and then the result was either, public facing dashboards, where we heard that providers check those dashboards every day to ensure that when they were walking into work, they knew what their patient population would be walking in with. We heard that it was nice for them to understand that it was driving where we were going with vaccine outreach. Or in New York, we did public health detailing where we were sending public health detailers into primary care physicians' offices to talk to them about vaccination and answer their questions. And the only reason that we knew where those folks were is because they were telling us and sharing data about their own patient outcomes securely. And so I think during COVID, what we really saw in pursuit of more equitable outcomes from both disease and vaccination was this true, authentic exchange of data that I'm doing this with my hands because it really, bidirectional doesn't really explain it. It really was omnidirectional. And I think folks felt that for the first time. Like, I give you something happens because of it. Isn't that nice? And so I think that was a really foundational piece as well. I'll just say lastly, I think what we are seeing across, the exemplars that we're sourcing and hearing from folks is a lot about electronic exchange of data and how that not only drives, a situational awareness of what's happening, whether it's for COVID, Legionnaires, or measles, or asthma, right? And more climate-driven and environmental impacts. But also the rapidness with which we can then turn it around and do interventions that are visible to the public that better instill trust. And we all know how much trust eroded over the last couple of years. We won't get into misinformation, but that is part of what we're trying to do as well. So if anyone is doing really creative work on misinformation, we'd love to hear about it and amplify that. But the public needs to regain its trust by seeing that we as public servants and primary care providers as public servants of medicine really are serving them. And what does that look like? It looks like we are, producing these interventions based on what we're hearing from the ground and being transparent about what we're doing. So those are just some things, but I think we've seen a really big range of what folks are doing, from really technical stuff around like fire and health information exchanges, ECR, and the point of care testing and public health interactions, to really big picture, like broad community health needs assessment and aligning the timeline on their community health needs assessment and their CHIP for the first time ever. That's great too. Like that drives tangible outcomes. I know you do that in Maryland, many of you across the state, but I think that range really speaks to how much amazing work is out there happening, has been happening even before COVID. But the more we talk about it and amplify it and replicate it, the more, funding ties to how we talk about things and kind of present the evidence of what we're doing. So that's an important aspect, but it really is critical to that rebuilding of public trust and even, trust and acknowledgement within our own fields as we're experiencing so much burnout and feeling a lack of, public acknowledgement or self-acknowledgement in the work.
Excellent. Thank you. Thank you. Thank you. Lillian Bagnall, thank you.
Thank you so much, and thank you for this presentation. I'm so excited.
Great.
But I wanted to ask if you have when we talked about misinformation, we talked earlier about we can only operate at the speed of trust, and I think that that's very true.
Yep.
And one of the challenges that we have is in amplifying our successes. So have you seen a model where not misinformation was the public health issue, but how do we have surrogates in the community, not only brokering that trust and that relationship, but also elevating the successes to get more buy-in at the granular level?
Yeah, it's a great question, because I think that it is easy, like what you're alluding to is it's easy to say like, look what we did, and like want credit for that. But when you're operating in a system of growing distrust, but also earned, governmental distrust in communities of color, and rebuilding trust, particularly after the early days of COVID and the inequities that we saw. I think that what I have seen work really successfully, and I'm not going to say it's like a magic wand successful, is that letting organizations on the ground do things with your resources, with your information and the facts, putting it in their own voice. We did this very frequently, not just for COVID, but then shortly after COVID with MPOX, or not after the height, with MPOX, and with measles in New York, and we're seeing it now with measles across the country. Putting the information in the hands of community leaders and saying, go forth. I mean, it does not come naturally to me as a public health communicator, but it is the right approach. And it's saying, what do you need help with? Do you need help with copies? If I give you the information, putting it in your language and your voice and letting you deliver, where do you want mobile vans for vaccination? Where in your community do we need to bring these resources, and let you be the ones handing them over, because you are the ones that they trust. And that's how it should be. And that's absolutely fine for us to be a little bit more hands off. It creates the rub of like, then we don't get to say, look what we did as overtly, because there's not like a brand on it. But I think that's okay. Like, it is okay to take a step back and let the folks who actually have trust carry it into their communities and have those tough conversations in New York. And I'm sorry to keep coming back to New York, but it's a great model that we used for a misinformation response team at the health department, where we used both like environmental scans that we were doing, but also our community partners to come in and tell us, like, in this community, this is what we're hearing. In this community, this is the word on the street. This is like what they need. They need a flyer with these 5 things on it to combat the misinformation. And we need to give it to all the pastors in this neighborhood. And we were not the ones out there giving it to them. We could talk about the work of the misinformation response unit, but we were not then talking about going to those churches and delivering the information. That was for the community members to own, and for them to galvanize, pride around on their wins.
Thank you very much.
Yeah.
Thank you.
Yeah, thank you. It's a great question. It's a tough one that we have not yet cracked, but I think we need to keep trying and not wring our hands, and not saying you are, but saying, like, oh, we can't touch misinformation. But for the communities that we're impacting, they don't have a choice. So how can we support them even if we can't be out there, ringing the bell on what we're doing?
Great thoughts. I think, a couple of the items you touched upon are certainly relevant to all our work groups, but in particular, I kept hearing themes about communication and public engagement as a priority area for that intersection point of healthcare delivery and overall public health, and the data as well. So I'm curious if any members of the those work groups in particular, or any other work group members who are participating online or in the room, have any additional thoughts or comments, questions for Chelsea. All right. Well, Chelsea, thank you very, very much. Again, just, I hope you're safe, and I hope your community is safe, and we're all thinking of you and wishing you the best. Again, thank you for joining us today and speaking about the coalition. Thank you for your thoughts on the intersection between public health and healthcare. I know that is something we're continuing to explore as a commission, and this is really a great food for thought. Thank you.
Yeah, thank you so much, Dr. Brewster and everyone. And I hope you'll join us and or reach out with questions and your own stories. You know where to find me. Thanks.
Thanks. Thank you. Great. Thank you, everyone. What we're going to do now is move into a little bit of mission. How's everybody feeling? Do we need to stand up and stretch a bit? Move up, stand up. Because we got to get that brain energy waves going here for our next step. There's a little work. So I can see some around long there. Those online, if you get a chance to stand up and stretch, it's always good to do that just to kind of get your energy on for the next day. Oh, great.
Okay.
All right. Wait for this. Seriously. Okay. So this has really been a lot of critical content today. We've seen over the past 5 months or so this commission through these meetings and the presenters and conversations we've had at these meetings through the work groups and all the work of the work groups and the presenters and conversations that those work groups have been having. We've really been talking and learning quite a bit about Maryland's current public health system, some of the challenges within that, some of its unique features and strengths, as well as what's happening on a national level and what's ahead of us in Maryland that we need to tune into. So we wanted to have a little bit of discussion time for the commissioners, and the commissioners, hopefully you've had a chance to reflect a little bit over the past several months, and especially in the past few days or so as we've gotten ready for this meeting, and we prompted you previously with some questions that might inform this conversation, but really looking at the broader vision for what we want the public health system in Maryland to look like, because what vision is it trying to achieve here in Maryland, and what are we looking to as being the priority aims for Maryland's public health system. When we were at our last meeting, Fran gave a very rousing call. I would say call to action. I'd say call to visioning. So that's partly why we thought it would be a good time to step back a little bit from the presentation aspect of the commission and have some higher level conversation around the vision for the public health system in Maryland. On the slide, if you can see, we're just putting some thoughts out there, just some thoughts for the commissioners to consider and hopefully provide some comments and some discussion.
So this slide is really kind of an appreciative inquiry oriented set of questions to ask us, what is Maryland doing well? What should we scale? What's preventing us from achieving excellence? And then the next set of prompts that were sent out really is looking towards that future state in terms of how would you describe or define what you want Maryland's public health system to be, which I know may be challenging or even frustrating for some folks who really want to get down to brass tacks and start working on the change. But before we really get into kind of the implementation side of things, it's important for the work groups and for the broader commission to have kind of shared vision and buy-in on what this future state really kind of looks like. So I think it will help all of us ultimately end up with a much better sense of where things go. And we'll keep building on these exercises. So this is not something that's one and done. I know Tosin had proposed a particular framework that would take this a bit further, even within some of the work groups. So definitely would love to have some robust conversation. We'll take notes about this, and I think it ultimately will help enrich a lot of our background as we're writing the report and incorporating certain things to really get less of a scholarly exercise and more something that really resonates with why this mission is so critical.
I'll open it up. Anybody wants to jump in?
Is this open to commissioners and non-commissioners?
Actually, I mentioned commissioners just because you'd received some of these talking points by email.
Right.
But certainly if the commissioners are speaking, I'd love it if any of the work group members or work group co-chairs would like to give some thoughts as well. All right.
Well, I guess I'll offer. Thank you. Oh, poor Barbara. So
Just say your name, Barbara. and-
So I'm Barbara Brookmeyer. I'm the co-chair for the Governance and Organizational Capability Work Group. And I'll just start with this one here with this slide. The first one, what characteristics would you use to identify an equitable public health system? I would say that reminded me of our earlier question. What are the vestiges of colonialism that we're not even aware of in the existing system and in the way we're even thinking about this? Part of it is related to governance. Our local boards of health are the elected people in many. It's allowed to be the people who are elected, and we know in some jurisdictions that might not be representative of the population in those areas. There's some people don't even have a voice through the local government. So anyway, so I would say the question is what characteristics. I'm worried, I'm not even aware of how the past is just ingrained in the way I think about how we're organized and how we do our work, where we do our work, but really how we're organized for the governance of the organization.
Thank you.
I'll follow my co-chair, my co-pilot and partner in crime.
And Fran Phillips is speaking.
Yeah, thank you. And thank you for this discussion, for earmarking on the agenda a little bit. And I will listen. I just want to make the point really to underscore what Barbara just said, that equity, and you heard a lot about health equity today. It's just got to rise to the top in terms of our, I guess that's the first one again. But it's hard to imagine a future that is not a priority. That is not. Second thing I want to say about that first statement is that as Barbara talked about the mental models that we all carry around that we need to really kind of make visible and think about. The public health system is a mental model, and I would suggest that it's too confining. We operate in an ecosystem. It's not our system. It's not the hospital system. It's a health ecosystem, and I know that our scope here with this commission is a little narrower than boiling the ocean or boiling the whole ecosystem. But I do think it's critical now that we start looking at those boundaries of what we think is public health and what isn't, and re-examine that, because the world has changed and is continuing to change in ways that we just really have to be nimble in our thinking about this term public health system and what that is kind of inadvertently stealing. So I just kind of call that out. Thank you.
All right, is it the 1910 model.
Right.
But he's still in that model. I can read on,
So
I'm
sorry,
sorry.
sorry, just let me know this.
Those are not education, sorry. I can read on the first point, the characteristics, that we used to identify and everything public health system. We all know there's a long standing, history of, social injustices and inequities that continue to, show up, in the way we do business, not just in, public health, but even in healthcare. So I think we really need to start looking at, political determinants of health. Let's talk about the social determinants, especially that, for this condition and how we know that will play a role. So, as we think of, as we're doing our assessment, I just feel, tying into equity, we need to start maybe taking a different dive at the policies that exist and how maybe assessing those can inform our recommendations. So, policy that exists because across all the programs, not all, but the ones that are listed in the legislation. I'm just looking at the political determinants. Okay.
Here to say your report, sorry, Megan Filati, Mercer Maryland. Policy now. I'm in the community engagement work group. So I think what I think of when I think about in general in Maryland, but overall, I think one of the main components to think about when we want to improve public health structures across the state level is, and this actually touches on multiple points here, and it ties into what everyone has said. I think really having a true public and patient integration approach. When we talk about engagement, we have to really have a good understanding of what that means. Without inclusion of the public as equal partners with the system, you cannot move that needle because all transition into the population. We talked about earlier the social kit, how we need to have a combination of health and social care. This is how you really move it forward, but I think we really have to think about including the public in decision making from step one to the end. And that means they truly help people include it. That's true inclusion and integration for the system. I don't think we're anywhere near that at all. There are strategies to do that. There are other states that perhaps are doing this well, but there are certainly other countries, other developed nations that are doing this. It's a mandate within their system, and that's why I think we're able to move the needle a little bit more because they have that structure in place. I think you really need to think about it. That's not the policy, that's the politics, all the things we talk about. But I think that's a huge area that we need to think about. How do we create this a system where we can have that inclusion without the barriers of church community integration, community engagement, because there's a lot of structural barriers there already. Something as simple as having community members being involved in research projects, getting approval from ethics boards for them to be equal partners, to publish, do this, do that. These are very basic things. But I think once we identify a way to do that, that's a huge component to having a more successful public health structure.
I'm speaking to my sacred comment. I'm the chapter one. The commission, I wanted to reflect on the Institute of Medicine reports right back. First was the future of public health report, where it said public health is in disarray. That's been 24, 25 years ago, where we knew what the problems were. 2 years later, the IOM had the report on the future of the public health. And so I'm just taking and looking at this, making a question and your comment, Dr. Common, is this is the public health system. When you do that, what CDC used to have on their website, I don't see it anymore. The network, I think that you have, on your.
I'm sorry, can you speak louder?
Actually, somebody right here, they can put that voice down. The mics are really important thoughts to share. If you wouldn't mind repeating it, thank you. Yeah, I just wanted to, was reflecting on this conversation, which is really important. And thinking back to what the Institute of Medicine report had done back in the late 90s, I believe, like even earlier than that, on the future of public health, where the phrase or the press release was public health is in disarray. And then a few years later, when there was the report on the future of the public's health, it opened up the floodgates of all the players, as they call them, and have a relationship with the health, with the public. So what I'm posing is, instead of a public health system, we're really talking about the public's health system. And I think their comment about how to include the public and how to include the community is really the flip that we're all doing, whether it's in research mode or differences with doing research, or whether it's in operations of healthcare systems. So this concept, I think that is one that
Yeah, this is Boris speaking. Yeah, it goes back to sort of, the working group that's dealing with governance. I guess if I begin to look at the future, right, and we've got to, from our first presentations talking about local health departments, the reality is we're kind of a mixture of things here at State of Maryland. And I guess from my perspective, not having worked at the local level ever in my career, so my bad is, I was a fed, and that's all I've ever seen. So those of you who work at local public health or state public health, I actually look at you as the real public health people to some extent, right? You're down in the trenches doing incredible God's work, let's call it, right, for the good of our communities. When it comes to governance, I guess part of what I'm looking for out of this is what are going to be our recommendations of the governance? Because, much of you talk about sort of the political nature of public health and all its manifestations, but how do we ideally run it? And I tread on thin ice here, because part of it is when we begin discussing, the current political structure and the political interplay at the local health level. And will we have enough data or enough strength to say, well, you should look at it from a whole different angle, State of Maryland, or decision makers here in Maryland?
Well, just to pick up on that, the governance and organizational capabilities work group submitted a bunch of potential questions to key informants who we would characterize as, some of them they're the big bosses, they're the decision makers. And those questions really are aimed at teasing out, what do you think about, policies and funding and all that, but what do you think about the power dynamics? What do you think about the mental models that the state carries around, the state and the local health departments carry around for the local? So we hopefully developed kind of inventory of provocative but not inhibiting questions that really do get to the point of governing and the policy and decision making. The authority and power that's vested with local health officers, with local boards of health, and with the city, and then with the public. So I don't think that the governance, our work group is pretty much onto that. For example, our meeting last week was with, we had a lengthy a lengthy discussion with the attorney, the senior attorney at MGH, who represents local health departments. And she's got a staff of two, so with 3 attorneys who largely define on a case-by-case basis what is that relationship. And we determined after a good and very lively hour of discussion that there's a lot of ambiguity and there's a lot of questions about this. So believe me, Boris, this is going to come forward in the governance, some of the suggested recommendations that really have to do with how can we be clearer in our responsibilities, mutual responsibilities, and our accountability. So I think that we're on to that. But that's within that, as Deshaun said, in the sphere of public health system, but getting a little bit broader to what Josh was talking about last time, is it is really now blending into population health. And where's the governance on population health? It's not in the state health department. No, it's at this gubernatorial commission appointed, there's 7 appointed commissioners at HFCRC. And now there's the Health Equity Commission on Health Equity, which we heard about, is going to be the board that is going to be overseeing population health in Maryland. And that's a good one. So. And you got so
I enjoy doing that.
I can see he's. Get a background out there.
Really, what Tosin was commenting on really resonated with me, which was the interplay of politics, policy, and how public health is, and how does that, how does that then influence the outcomes? And I think for me, being from a more rural jurisdiction that is further away from where the central Maryland populous areas tend to be, I feel like it's so important for us to be responsive to our own local communities. That is such a I think a strength of Maryland, that we have local health departments that are so are working really in a connected way with their communities and the dynamics of their local partnerships and their local healthcare delivery system and so forth. So for me, it's very important to preserve that, but to not just preserve it, really to accelerate that, right? I feel like the alignment is critical and important around the state, because we all need to pitch in to achieve the bigger benefit for the entire state of Maryland, and that is absolutely important. But it's also, and again, maybe it's Camille's word of both and type of thing. It's also let's preserve the ability to be responsive to our local needs and to be unique if necessary in that response. I think that's critically important. And how do we enhance that? How do we give our localities the tools and resources to be able to be most responsive to those local community members and local needs, and build those local partnerships? If you could just say your name and your work.
Oh, Matt Levy, I'm the co-chair of the. So I'm relatively new to the public health side of this, but I've been in healthcare for a long time. And I was trying to formulate sort of what I if you were to say here's a magic gene bottle that you could shove it and ask them for a perfect solution. I had trouble with that, but one of the things I think is a challenge for all of the parties is consistency in time, because consistency is each year we have to figure out what we're going to do toward the next year. So there's no longitudinal approach to change. So changing over a generation is really what we need to do, right? We need that time and the consistency, and part of it comes down to money and a consistent amount of money. I mean, we're 60% funded by grants. You can't live your life that way, because some of those grants are multi-year, and those are not same as a grant you get for 2 or 3 years, and you got to start this project, and the project works, but then there's no funding to finish it or take it to the next level, even though it might be a great program. And I think that consistency of allowing us to take a breath and look at that expanse of time to make true change and work with the community on multi-year projects that we know have evidence behind them, or we're building the evidence behind them. I think that is a key factor to a public health system. And so the the time factor, I think, is really, really critical there, and that system. Plus, if we learn something, then we should be able to apply it across other jurisdictions, right? If one jurisdiction is doing something really well, because they got funding, and we say that's a big project and it actually made a change over time. And we also fund this jurisdiction here so that we can now expand on this and make it a huge motivation. So that was sort of it's to the heart of what I think is important. I don't know how you do that here. And that practicality, I don't know if you're something, but this is about asking for what we need. So.
Any thoughts from, I know some of the commissioners online are tuned in. Do you have specific thoughts you'd like to contribute?
You know,
Yes, please. Go
while our online commissioners are thinking through, you know, I do read them.
So Michelle Chester, CSI.
Thank you.
Sorry, just so they can speak.
Yeah, my mind is going to your comment and to what you just shared, and two things that you percolating through. One, that local health departments and state health departments are 60% funded, and so health departments work towards the outcome of the funding. And so there's not a whole lot of flexibility in the funds to do those innovative things. But as you're thinking a decade down the road, what are the opportunities? Like, I think we need to consider what are the funding mechanisms that can be shifted to in order to do that work. And then when you were sharing about engaging community, I think the other thing that we need to be mindful of is how do we reimburse community or pay community for the work that they're doing and the input that they're sharing with government entities, academic institutions, and that is, think about community. Do they have the opportunities to write those great grant applications that then allows them to be participants in some of the work that's happening at local state health or our state? So I think those are some of the considerations. But what's the downward way that we should be thinking about this in terms of funding mechanisms to support more community organizations to help us do this work and to be participants in the movement. And that goes what you said, Barbara, in terms of who are the players. Like, there are elected officials in these roles that don't necessarily look like the individuals that they're representing, but it takes a lot to say, I'm going to put my name on a ticket to represent this community as those individuals, and that's part of the political determinants of health. And I would suggest that we also look at Daniel Dodd's book, exactly that, the political determinants of health and how that impacts the way we think and do the work.
Thank you. Thank you. So this is this is an ongoing journey, of course, and we've had some, very thoughtful discussion over many, a handful of months now, and certainly the comments today and what we're going to learn as we go into all the site visits and the listening sessions and move into assessment. There'll be much more to consider for us moving forward. But again, let's keep our eye on big picture items for Maryland, big picture items for a big picture approach to designing or developing the public's health. Thank you, Tushanta, for writing that for us. And we'll certainly build upon this visioning conversation in future meetings here. Thank you. We're going to wrap up with some brief announcements from any of the work group co-chairs who were able to join us today. And let's go ahead and start. If anybody's on from the workforce work group and wants to give a brief thoughts, any thoughts you have of what's any updates from your work group that you'd like to share?
You mean it? It's Sue. I'm having some technology challenges today anyway, but I sent my work group update to Sarah because she said we were running short on time, but I did want to mention that last week when the Deputy Secretary for Behavioral Health was here, I had mentioned this work group and that we were focusing on behavioral health. And she reminded me that they have a commission for behavioral health, and that rather than duplicating a workforce survey or workforce recommendations, maybe we should collaborate together. So I did want to throw that out there.
Great. Thank you, Sue. Definitely noted it. And fortunately, the Deputy Secretary of Behavioral Health is actually on this commission. And so hopefully she'll be able to help guide some of the way we're looking at the integration of behavioral health. Does anybody, I see both Fran and Barbara are here in the room. Did either of you wanted to give an update on the governance
I just
organizational
mentioned
video?
the, our discussion with the Attorney General.
Great, thank you. How about data and information technology? Dr. Levy's here, and then I believe Jay was joining us as well. Dr. Chandra. Oh, and Megan's here too.
So we've been meeting pretty regularly. We just, we're compiling a list of all of as many surveys as you can find, and just met on Tuesday to try to sort of pull the best questions out and have a rich discussion, and then just take them back and put it in the format, and then we'll look at that. And we're sort of designing how we're going to get the rest of the information, the informants, and everything like that. I know it needs to be coordinated, obviously, with the rest of the interview process. And we are trying to get the state's survey that they did for their internal health data and IT infrastructure, because we think that if we get those questions, we don't need the data, we just need the questions. They look at them and say, all right, this put them to the local health departments to see how different they are, so to compare what they got, what we got, and what the needs are. So I think it's really important if the commission can help us get that. We would appreciate it.
Yeah, I did get a response back, just confirming what I was asking for, so hopefully.
Okay.
That was,
That was fine.
yeah, also our inference here, very, so.
I'm giving you old information here. And then we're gonna talk about alternating the bigger group and then our smaller work group every other month, so that we don't hire them together. I think that's a good progress.
Thank you. All right, the funding work group, any thoughts from the funding work group?
Hi. Dernisha wasn't able to stay on the call, but she wrote to me and wanted me to update that they're continuing to gather information and listen to guest speakers as they prepare for the first draft of recommendations this summer. So I'm not sure if the co-chairs are on it, want to add anything to that, but wanted to share on her behalf.
Thank you. I thought I saw Roger, Carol. No, Alan, did you have a comment?
No, that's okay. I was just going to mention from the funding work group, we did hear from the Maryland Hospital Association on community benefit spending. And we're looking at some sources of private funding for public health. So that will continue.
Thanks, Alan.
Sure.
If no other updates from the funding work group, we'll go to the communications and public engagement work group.
Hi, everyone. Sylvette Latouche Howard. So I'll be reporting on behalf of the Communication and Public Engagement Group. So our group has been doing a lot of meetings, lots of discussions, and it's a very vibrant group. With that said, we've come up with two sets of questions. One that is for the public health agencies, and then another one that's more for the public, the forward-facing public, so those public assessment questions. And the main concern that was coming out from our work group the last time that we met was about the urgency of time. And I think that theme was kind of mentioned throughout the day, that now that we're in a prime time for being out in the communities, asking questions. Is there a possibility that we would be able to have these questions asked in the community in various places by the summer or during the summer, seeing it's a prime opportunity? And we know that we just watched the timeline and things are going to take some time. Definitely the public health agency questions will be able to go with everyone else's own, but is it possible for the questions for the public to actually go out sooner than that? And so that probably will take a lot more further discussion than 450 can do with us. But that was one of the main issues that came out. We've been having great speakers coming to share with us how communication happens from their agencies and some of the challenges and also the opportunities. And so we try to incorporate all of that within our questions and our discussions.
But thank you. Thank you. Okay. Great. Well, appreciate all of the work of the work groups and certainly the work group co-chairs for leading them through that process. There's I know an incredible amount of dedication that driving the process. So thank you very much for all that work. We are approaching time, so I'm going to go ahead and adjourn the meeting unless anybody has any significant points they want to bring up. Nope. I do want to mention, actually, let's go ahead and call for a motion to adjourn the meeting. Any seconds on? Okay, thank you. And then all those in favor of the adjournment? Thank you. Thanks, Alan. I see your hand. Okay, thanks, Nicole. Excellent. Thank you so much, everyone. And I do want to mention for those of you who are interested